For sure.
All right, here we go. All right, and now here we go. Hello and welcome to Neuro Challenge Foundation for Parkinson's. We are so excited that you are here today with us to hear all about rewiring the brain, how neuroplasticity offers new hope in Parkinson's disease. And this is going to be offered today by Dr. John Conde. And he's going to tell you a little bit more about himself in just a minute. But I wanted to give you a little bit of normal housekeeping here on a webinar, just so you remember we cannot see you. We can't see you put your hands up and ask questions. So what you need to do is, as you think of a question for the doctor, go on over to the Q&A bubble at the bottom of your Zoom screen, type that question in for us, okay? It would really help if we had the questions to read off to the doctor at the end, because we can't see you and we won't be able to hear your voice. But we are very, very excited about this today. Also, if you have any technical difficulties out there with hearing us, don't be afraid to put that also in the Q&A bubble to say that you're having issues and we might be able to address them from this side. We are also recording this webinar today, so it will live on our YouTube channel, on the Neuro Challenge YouTube channel, in about a week after we get it down and edit it. But we are happy to be able to show this to you today. So without further ado, Dr. Conde.
Thank you. Thank you very much. I'm super excited to, like we were talking earlier, to be here and be able to share kind of maybe some new information that maybe most haven't heard of. Although it's really not new. It's we've been understanding how this works for a long time, but being able to share what it means and how it can be applied to a patient with Parkinson's and it's always great to also offer hope because there are other things available besides medication and some of the more kind of invasive procedures for tremor and that type of thing. So, okay. So today the presentation is called Rewiring the Brain. We're going to really focus on how neuroplasticity offers new hope in Parkinson's. And just a little bit about myself. I practice in South Florida on the East Coast, and our my practice name is Functional Neurology Brain Center of Florida. Been practicing functional neurology for a little over 20 years, and I'm on several different committees, including the American Parkinson's Disease Association, where I've lectured and presented on panels and that type of thing. I also lecture to other physicians across the state of Florida and even also across the country. I've done specialization training in movement disorders, really focusing on cutting edge rehabilitation, right? Low tech, but also with leading technologies that we have available, which are really neat. And we'll kind of get into some of that. Okay, so just some quick statistics. I always like to open up with that so people know, hey, I'm not alone. This is this process is pretty. It's becoming unfortunately more common. As time goes on. The good news with that is that means more research, more dollars devoted to it, more time, more focus, which will help everybody. 90,000 people diagnosed each year. About 1.2 million are predicted by 2030. Males, we see more than females typically being affected, although we see plenty of females in our office as well. We see that the Rust Belt has a little bit of a higher incidence, Northeast, Midwest United States. Primary risk factor is age, so we'll talk about, there may be some other things that can contribute, but that is age is a primary risk factor. Increased incidence, 65 and plus. And there's a combination of genetics and epigenetics that are in play when we look at Parkinson's. And epigenetics means environmental aspects, right? So we know, yeah, as we get older, there's a greater probability of some of these areas in brain kind of slowing down, degenerating. But in addition to that, the things that we are exposed to that we do on a daily basis or things that we ingest can have an effect as well. So some of the major symptoms, okay, and we'll go through some major and minor. Most people have heard of the tremor, right? That's the rhythmic shaking and that type of thing. They come in all different types of presentations. Sometimes we'll have a kind of a flexion extension tremor, or we can have a supination pronation or pill rolling tremors. And not everybody has tremors. People associate Parkinson's with tremors. To be honest, I would say a good portion of what we see is non-tremor related Parkinson's. And we'll get into that. It's more the slowed movement, the bradykinesia, the stiffness, the rigidity. That's really what kind of creates more impairments into daily living is more of that and less of the tremor. The impaired posture, the forward gravitational pull, the balance issues, the loss of the automatic movements, things that we take for granted, getting up and starting our walk, we take for granted, right? Turning, we take for granted. Stopping, we take for granted, right? But these are things that are affected. These start-stop mechanisms are affected with Parkinson's. Speech changes, loss of intonation, more soft, kind of slurry speech at times can be affected as well. And then, of course, writing changes can occur. Penmanship, smaller, more illegible writing can occur. Okay. Some of the minor symptoms, we talk about cognitive difficulties, and we'll talk a little bit about it in a bit here about some of the cognitive components with Parkinson's. There is something called Lewy body associated Parkinson's, right? Lewy body dementia. And that means basically that these misfolded proteins, which we'll talk about in a minute, start to affect some of the cognitive centers in the brain as well. In fact, many times we'll see, in addition to the Parkinson's pathophysiology, we'll see pathophysiology that's related to Alzheimer's. So we may see some what we call tauopathy or different other proteins that are like beta amyloid plaques that we may see occur together. Okay, and that's the whole Lewy body type of dementia. Depression may be associated, swallowing difficulties, chewing, eating may be a little bit more difficult, sleep problems, kinetic dreams, kind of very vivid dreams where you're acting it out within the dream. In fact, sometimes this can be a precursor to the diagnosis of Parkinson's. We'll talk about some of those here in a bit too. Bladder difficulties, and of course, constipation being another one that can be an issue there. Okay, now in terms of the physiology of it, I'm going to try not to get too scientific, but you have to have a little bit of an understanding. So when we talk about plasticity, neuroplasticity, we can kind of refer to some of this. So the biggest, the most impactful changes we'll see with Parkinson's are these proteins that are normally seen in these cells, okay, in our brain. But what happens is that over the course of the disease process, these proteins start to misfold. They start to become almost out of shape, out of proper morphology. And the main one that we'll see primarily with Parkinson's is this alpha-synuclein protein. And that's the one that we'll see in there that will misfold and affect the cells in the brain that produce dopamine. Okay, and that's kind of when you remember the carbidopa, levodopa. The whole purpose there is to help to produce or artificially provide dopamine, right? So this alpha-synuclein. Now, tau proteins are another type of protein that we see more often with dementias and Alzheimer's, but we do sometimes see it associated with Parkinson's as well. The area of the brain specifically affected is called the basal ganglia. Maybe you've heard of that, the substantia nigra. This is kind of ground zero. This is kind of deep brain structures underneath the cerebrum. Okay, and that's really where that dopamine is produced. And we have a pretty good understanding about the circuitry that goes in and out of this basal ganglia and how it relates to other parts of the brain. And that's super important when we talk about neuroplasticity because we can affect other areas to compensate for some of these deficiencies. Dopamine plays a huge role in regulating movement, ensuring fluid, smooth motion of the body, of the limbs. Okay. Leads to involuntary movements, right? Jerking, tremor, rigidity, which is that whole bradykinesia component as well. It's kind of important to understand that kind of where it all starts. So you have an idea as to why you're taking the medication, maybe why you're doing the therapy, why these things kind of matter to make a change. This is just a little a graphic here showing basically a brain that is producing dopamine, right? These neurons that are producing dopamine, and you'll see, increased of those neurotransmitters, and then Parkinson's patient or individual that it has impaired production, and you'll see that it's the quanta, the density, the volume is much reduced. The picture in the middle is that substantia nigra, the area within the brain stem where dopamine is actually produced. Here's another picture, kind of looking at what a normal part of the brain looks like, and then an area of the brain that's involved with Parkinson's. And you'll see if you look at the picture kind of below, you can see that that the substantia nigra loses some of its coloring, is its actual makeup, and it starts to become much more pale, and that kind of highlights some of the changes that occur at the cell level. Okay, so in regards to Parkinson's disease, we've been able to, over the years, to have a better understanding of how to describe or to subclassify Parkinson's disease. Okay. And so there are more than these two types. There's a couple others, but these are really the most common types that we'll see. Okay. One is called the akinetic rigid type. And those are patients that are really more dominantly rigid, stiff, slow, that type of thing. And then there's the tremor dominant or the hyperkinetic type. Those are the ones that have just really more intensive tremor than they do the fluidity and movement issues. Okay. The akinetic rigid type, we'll see a lot more postural instability. We may see something called camptocormia, where you're leaning forward, or you feel like you're moving and falling forward. An interesting thing about that, a Parkinson's patient actually has a lot more instability going backward. Okay. So what happens is subconsciously, the brain starts to enact this kind of mechanism of protection to lean forward. It's not that your neurology is making you go forward. It's actually you trying to compensate. And that's that forward type of presentation. Gait difficulty with this akinetic type. It's a faster progression, though. We do see that. Not all the time. So if you're thinking, and if you're sitting there watching and say, oh, yeah, I don't really have tremor, but I'm more rigid, I'm going to have a faster progression. No, we just see that there is some correlation there. Not always. It's not a hard, true fact. Okay. But we do see some of that. And there is a little higher risk of dementia there with the akinetic rigid type. We do see more Lewy body kind of transference and that type of thing. Tremor dominant, the hyperkinetic one, is the tremor based, right? Not to say that they may not have some of the rigidity and the issues there, but maybe they're more dominant with the tremor. We see in research that this is a slower progression and has a lower early dementia risk. Okay. Again, there can be crossing symptoms here. This is the generality of one versus the other. Okay, great. Now let's jump into why we're here, and that is neuroplasticity. Okay, so neuroplasticity, what we've seen with this and how how this has come about, honestly, it's been probably about 20 years in the making in terms of really heavy research, understanding the neurophysiology, how things work at the cell level. First, kind of establishing how this works and what it actually means, and then leveraging it to really maximize the therapeutic intervention, right? So a lot of the leading centers, including our center here, leading brain centers, are really incorporating and leveraging and really trying to make the most of using and incorporating neuroplasticity in rehab. So it's the ability for the brain to reorganize itself. Okay, literally change connections, change the way the brain is working. And another important fact to know is that our brain is always changing. This is a kind of again, a relatively new understanding. The old thinking was that once the brain is developed and you're in your 20s, and that's the brain you have. There is no, deviation from it. Now we know that's completely not the case. Our brain is constantly changing every second, every minute, based on experience, based on what we're learning, based on what we're doing. Some areas enhance, some areas diminish, just the way our brain works. So it's the ability for the brain to reorganize itself, the ability for the brain to change. Okay, we know the brain can change. The word plastic actually means changeable in Greek. So we know that there can be a change in brain. Brain activity associated with a given function can be transferred to a different location. The proportion of gray matter can change, and synapses may strengthen or weaken over time. Okay. And basically, what we're saying in there is that, if we do something over and over again, and it's strategic, and it has a really good effect on a certain area of brain, well, that area of brain can actually change. Some of the synapses, the connections, the gray matter can actually change. The white matter. We can make change in that with repeated stimulation to that area. And it doesn't. And when I talk about stimulation, it doesn't have to be a direct electrical stimulation to an area. Okay, although there are things we use to do that. This can also be as simple as an eye movement that has a great effect on a certain part of the brain, right? It may be a certain type of way that we spin in one direction versus the other that can have a preferential activation of a certain part of the brain. It could be, doing a cognitive task that can have a specific area of brain that it. So there are targeted areas, therapies that are done to stimulate certain parts of the brain, and that stimulation, as we increase the volume of that, can actually change the neurocircuitry. The actual cells can change themselves. So neuroplasticity is the capacity of the neurons. Okay, that's what makes us go, or the networks in the brain to change their connections and behavior in response to new information. The brain loves novel, new, different. So whenever we're doing any type of rehab that's targeted to a certain brain area based on what we're finding with that patient, we're going to change the way we deliver that, just because we want to have variation. The brain really thrives on that. It'll stimulate and create greater connections if it's more new. Sensory stimulation is a big part of what we do, and what's done to a brain to make it enhance. And then, of course, neuroplasticity occurs with development as we age. That's neuroplasticity. The brain is changing and remodeling. We can have damage to the brain, and that can produce something called maladaptive plasticity, where just as the brain expands with all new connections, it can actually also truncate and reduce if there's damage or just things that are toxic to the brain that can actually reduce its function. And then, of course, dysfunction of brain can actually produce maladaptive plasticity as well. So these neural networks, they exhibit what's called modularity. They're self-check systems. Don't worry about too much about all that really detailed information, but it's a very advanced system that takes place in our brain. The brain knows when to upregulate or increase connections. It knows when to decrease based on what's going on. It knows to not kind of overdo something if it's going to be bad for the brain, right? So This is all a breakthrough in the 21st century. Like I said, about 20 years, maybe a little bit more in the making, and it's the key to neurological healing. A lot of the medications that are being administered now, not so much for Parkinson's, but other ones are based on the fact of trying to enhance neuroplasticity as well. And again, that's just looking at nerve cells and all of those little connections in the brain that come off of those nerve cells. The purpose of any type of intervention with neuroplasticity is to enhance those connections, go from a 2-lane highway to a 5-lane highway. The more connections crosstalk we have, the more efficient the system works, the less rigidity, stiffness, the less tremor. That's the key to all of this. What dopamine does when it gets minimized with this disease process is that we lose crosstalk, we lose kind of overarching modulation of the system, so it starts to go kind of a bit haywire. So neuroplasticity in action, basically it's the ability of the brain to reorganize. We talked about that both in structure and how and in function. Okay. And how the brain changes, well, there's something called neurogenesis. That's actually producing new neurons, brand new neurons. And we know now that there are a couple areas in the brain that can do that. This wasn't an observed, understood premise years ago. In fact, we said, hey, if you damage your brain, you're not. We now know that in the hippocampus region of the brain, we can have new development of cells. There's a couple other areas as well where we can produce new cells. Now, it takes a long time. That's why when you have a severe brain injury, those areas just don't come back. But there are areas that can reproduce, which is a great thing. The brain changes by creating new synapses. We've been harping on that so far, but the synapses are really what help to drive the system. Okay. And again, the more synapses in the appropriate areas doing the appropriate things, the better the brain is going to work. New skills, experiences, all of that. Strengthening synapses. We can also, strengthen the current synapses that are there and available, meaning increase the intensity of the stimulation in those areas. So it's producing more neurological input. And then the brain can change with weakened synapses, right? Too. We've talked about it. If you don't use it, you lose it. That's a real thing. We can really lose volume in the brain and lose connections. And that can have a drastic, really deleterious effect for any person, but especially as somebody with, some challenges with neurology. Okay, so again, looking at nerve cells, that's the nerve body in the middle there, and all those little things are arms, connections. We really want to have a robust network of connections. Okay. I like this slide here. It kind of gives us some insight again into neuroplasticity and why and how we can achieve those changes in brain. Before I get really into that, I want to let me see if I can. Okay, before we get into this slide, I just want to spend a second here talking about what happens briefly at the cell level. Okay, so a neuron, which you see in this picture here, you have two ends coming together, right, to kind of create what we call a synapse or a connection. Well, the understanding is that when a neuron stimulates another neuron, and it releases something called nitric oxide and some other chemicals to make the neuron that it's talking to start to have genetic DNA change. Okay, we call this an immediate early gene response. Okay, and so when that neuron starts to undergo these genetic changes, it actually starts to produce new proteins, new connections, new cytoarchitecture for the cell, and it starts to really allow it to create more connections. So the simplicity of it is that if you have neuron A stimulating neuron B, okay, and remember, neuron A I'm going to just say was stimulated by, I'm going to make something up, a light that we kind of shone in your eye, okay? Light came in your eye, that stimulated these retinal cells in your eye and activates certain neurons, and that neuron A then goes down the line, activates B, C, D. Now let's talk about just A and B. A activates B. B undergoes some genetic change with that activation. It's literally fuel for it. Okay, it's fuel. Now, when it undergoes those genetic changes, it can start to produce new proteins. Now, can you imagine if we kept stimulating A over and over again, okay, in a healthy, graded fashion, that over time, we found through research that through a tetanic prolonged stimulation, that B is going to really become super, super healthy in terms of its proteins, its connections. It's going to just create this really robust system. And then now B down the line does the same to C and D and E and F. And that's how change is made. Okay. Now, when we look at Parkinson's, we talked earlier that that's the basal ganglia. We talked about the dopamine cells and all of that in that area. With these with strategic intervention, these therapies, we want to try to enhance some of these neurons that are still working, that are still producing dopamine, but reduce. And that's over here. We looked at this slide about strengthening synapses. So we want to strengthen some of those that are still there, but on the same token, we want to increase the new synapses in and around those areas, meaning that the basal ganglia is neuron A. Well, neuron A is going to talk to neuron B, okay, which helps to then coordinate motion, fluidity, all the things that the dopamine does. So by allowing there to be new connections and new synapses, we can take on some of the deficit that was caused by those dopamine cells not working so great. Okay. So it's a twofold type of approach. And we'll get to a slide that talks about strengthening the synapses that are currently there, but then also creating and creating new synapses with the surrounding structures. Okay. All right, so neuroplasticity in action here. 10 principles. We talked about that age matters, right? Younger brains are going to adapt a little easier, those types of things. Common sense, but I will tell you that the brain can change at any age. We do it all the time here. We have 90-year-olds, that we treat, and their brain can undergo change. The intensity of the stimulation, the targeted stimulation is important, right? There's a big difference if I were to kind of just touch my hand versus if I were to poke my hand in terms of the amount of nerve stimulation that we're giving it. It's the same thing with the intensity of the activation. Quite often, we may do a combo therapy where we're doing a certain type of stimulation, whether it's using a nerve stimulator that we'll talk about that stimulates a certain nerve that can kind of go into brain. We may combo that with an eye movement or some type of another coordinative activity to try to increase the intensity of the activation. Salience matters, right? It has to be something motivating and important to that person. We know in research that if we're doing therapies that are boring, there's that old saying, watching paint dry. The brain really, if we have functional MRIs or SPECT scans, the brain will see that it'll actually kind of not really shine bright in those exams, okay? But if we give the person something engaging, something that they want to do, something that's, exciting, that can be therapeutic, the salience increases, and the amount and the result of that activation is much more prominent, much more robust, okay? Time matters. Waiting too late to start the activity means a decreased capacity to change. We talk to patients all the time. The faster you can get into doing treatment, the better, right? In terms of especially our type of treatment within neurology. Now, of course, we'll still treat patients that have had a Parkinson's diagnosis for 10 years, and we still can make change, okay? But it's always a little better if it's been a couple of years, because the system is not so entrenched yet, okay? It's even better if we did it within the first couple of months, because everything is still, working relatively well, but we can get in there and start to make change immediately, okay? Which is the most important thing. Interference, can have an issue in terms of us being able to deliver the therapy. We talked about use it or lose it. That's an important concept there. Even when we're doing therapy, we give homework to do because there has to be a constant level of activation to really make the changes in the brain. Specificity is important, super important. And that's the whole, I've been using the word targeted stimulation. So we know in neuroscience what therapies, what treatments, what sensory motor activation will turn on a part of the brain. So we know that, for example, the front of the brain does really well with therapies that are involving anticipation or reaction time or having to do mental rehearsal or actual visual imaging is a great activator of the front of the brain. We know that the back of the brain, the cerebellum, the small brain, does really, really well with doing error correction activities of an arm or a leg. Maybe you're doing reaching activities or touching objects as they're moving, right? They're different types of things. The cerebellum responds great to motion or movement. So we may put a patient on a what's called a gyrostem and do motion-based therapy to stimulate that part of the brain. So specificity, very, very important. Repetition, the number, the times, how often we do it matters. There's some data that says you need to do about 70 reps to get true, profound neuroplasticity in a day. And within our meeting for treatment, we're going to achieve 70 repetitions. So that's a really important type of thing. Transference and all of these other things. So good slide here to look at because this is really what, how we were able to drive neuroplasticity and make the changes in brain. Okay. All right. So again, capitalizing on neuroplasticity, we talked about this a little bit already. We want to stimulate the nerve cells in that basal ganglia that are still viable and healthy, but maybe they're just not working to the degree that they should. So we may do therapies that activate right into that basal ganglia. Okay. We may want to stimulate nerve cells that are working kind of suboptimally in and around the area to increase connectivity. And then most importantly, we want to do surrounding structures as well that can help to create new connections, new synapses, to do a lot of the work that some of these nerve cells in that basal ganglia are not doing because they've lost a lot of their volume. So selectively activating brain areas through new information, sensory stimulation, and so on and so forth. So that has to be targeted, has to be specific, there has to be repetitive, and it has to be measurable. We've really worked hard in neuroscience within functional neurology to be able to measure changes. And so we know that, and that could be a whole other talk, but we have measurables now that we're able to measure when a patient comes in, different types of really evidence-based technologies that let us know how different parts of the brain are doing. And we may use eye movements with special goggles. I may put you on a force plate and measure different nuances of sway. I may do cognitive tests using certain software, just a slew of different things. We may measure pupillary reaction to understand how the autonomic system is doing. So it has to be really robust in that area as well. The main targets for neuromodulation or trying to make change, and we talked about, of course, the substantia nigra and the basal ganglia, but we also want to look at the frontal lobes. The front of the brain and the basal ganglia are almost inseparable. The front of the brain really modulates a lot of the substantia nigra, and then the substantia nigra goes and then feeds the frontal lobe. So again, a lot of work for Parkinson's rehab is done in the front of the brain. The midbrain, the top of the brain stem is important as well. The inner ear system, and then the cerebellum, we talked about the back of the brain, have a lot to do with Parkinson's as well. Okay. Each of these areas are respond to different types of targeted motor sensory stimulation. Very important. That's that specificity again. Just to show you some equipment that's used now in different brain centers. This is what we call the Dynavision D2, which is a kind of a 64 LED smart board that we're able to do different types of testing for reaction time, for visual spatial awareness, for right and lefts, ups and downs, just a slew of different things that we're able to look, test, and get feedback as to where the patient is at this moment. And then we'll do therapeutics to enhance or to activate to create changes in certain areas. We may use only a certain part of the board. We may use, reds and greens where you're having to inhibit and not touch the green, but touch the red. A slew of different things that we'll use to activate brain. Remember, we talked about salience. Salience again means that you need to do something engaging. It can't again be watching paint dry, or brain will just not light up the way we want it to. So this is one technology that's used in neuroplasticity. So it's a revolutionary diagnostic and rehab tool. We use it for visual motor. There's actually a neurocognitive screen in it that we use to get a little neurocognitive component, spatial skills, and it's a neurological process called efferent copy. The cerebellum and the frontal lobe are really, really affected by treatment and with this type of therapy. Okay. And again, the frontal lobe, we talked about that it's a modulator of the basal ganglia. And really it's a part of the brain that makes us human. Executive function, planning, problem solving, timing, anticipation, short-term memory, motor activity, just so much. So rehabbing it in a certain graded, measurable pace is going to be important for us. Okay. And this slide just talks over, we did a study with the Ricky Williams Foundation on post-concussive patients that were NFL football players. We used that device to measure, to treat, to do a slew of different things. A lot of times when we have patients that have multiple brain injuries, we talk about risk factors, but their probability of developing a tauopathy or alpha-synucleinopathy, like an Alzheimer's or a Parkinson's, goes up. Okay, so some of these retired NFL players, unfortunately, we see some correlation there. Another thing that we'll use, and this is more specifically for tremor dominant or hyperkinetic Parkinson's disease, is mirror therapy. I love mirror therapy. This was developed by Dr. Ramachandran, a medical neurologist, goodness, probably 30 or 40 years ago. And really the initial construct of the therapy was to treat patients that had phantom limb pain, meaning that maybe they lost a limb in the war or they had to get an amputation, but they're still having pain in a limb that's not there. Okay. And so what Dr. Ramachandran found was that by kind of tricking the brain into thinking that limb was still there, those parts of the brain can be worked out, exercised, strengthened, and over time that the pain would diminish and go away. So this kind of discovery has now crossed use, in terms of what we use it for. We'll use it a lot of times now to try to trick the brain to thinking that, hey, the limb is healthy, it's not tremoring, there's no activity there, and it'll fire these what we call mirror neurons in the brain. So for an example here, and we use medical virtual reality. That's really the go-to now. That's much more accurate for mirror therapy. But, you can do this at home using what's called a mirror box. And so basically what you would do is you would put the limb or the hand that has tremor, that would be in this woman here, the left hand. And in the right hand, you would put it in front of the mirror. Now, your job is to look at the mirror and do different types of exercises with that right arm. Okay, specific sets and reps. Over time, your brain starts to really think, hey, I see my left hand in the mirror and it's moving fine. There's no tremor. And it starts to actually have inhibitory mechanisms to get and reduce some of that tremor. Okay, this is another kind of mirror box. And again, it enhances these mirror neurons in the brain, specifically, again, the front of the brain. We always go back to that frontal lobe. It actually enhances the brain map of that limb in that frontal lobe in that brain so that there's more neurons dedicated to coming down, helping the basal ganglia to reduce tremor in those areas. This is the medical virtual reality. This is what we use. It's just more specific. We talked about specificity. It's measurable, and it also is much more free for the patient. We can do so many more things that way, and we're able to get really good results with it. That's the equipment that we use, the Virtualis equipment. Okay. We've also found that using neuromodulators have a good effect as well in Parkinson's disease. So neuromodulators are really very highly researched now. We're getting a lot more data. Most people maybe have heard of the transcranial or transcutaneous vagus nerve stimulation. That is one type of brain nerve that's used, but we also use things like the trigeminal nerve. So we have an external trigeminal nerve stimulator. We can also stimulate what we call the glossopharyngeal nerve, which is a nerve in the back of the tongue, using an RPSS device, which is a nerve stimulator, but we'll just get to the back of the tongue to stimulate that specific nerve. We can activate any nerve that we want to using these nerve stimulators, and they have a profound effect on creating that specificity we talked about with neuroplasticity, the repetition, the intensity, because we can increase the intensity of that nerve stimulation in those specific areas. Now, these are not TENS units. These are nerve stimulators, completely different. Okay, so getting a lot of you know kind of research as of late over the last maybe 5 or 10 years on these types of modalities, and they really are great, especially when you combo them with other therapies. And again, increasing the intensity of the treatment makes a big difference for neuroplasticity. This is one of my favorites. This is our gyrostem. This is a multi-axis rotational chair, and so you may think, what the heck? Why am I going in a carnival ride to treat Parkinson's? Well, a lot of great data as of late looking into motion-based therapy, which is this, and activation of what we call vestibulothalamic pathways. A lot of words, but these types of motions, specifically, we'd be doing motions in certain ways to stimulate certain parts of the brain, but motion in general will go up the brain and have an effect on that midbrain that we talked about, on the basal ganglia, on higher centers in the brain. And so we find that we really like to do motion-based therapy with Parkinson's patients. We see really good results with it. Obviously, most of the time, we're not going to put you in such a crazy maneuver. It'd be slow and controlled, but we see good change with that. And this is the multi-axis rotational chair. We use gyrostem. I think it's the best in the business in terms of what it can do. But it's computer controlled electromechanical multi-axis device. Okay, and it helps to enhance balance, coordination, cognitive function, motion induced stimulation, unleashing neuroplasticity, and it helps to really kind of sensory load the area so that we're activating, creating that intensity of activation. And quite often what we'll do with that as well is we may combo, if you look at the device itself, these white kind of little circles, those are targets. And sometimes we'll give a patient lasers and they can deactivate targets as they're spinning, trying to engage more frontal cognitive work as well. And it's really profound, really profound. We see really great results when we combo that with therapy. Okay, and I'm going to spend a minute here just talking about some dietary considerations, and then just some day-to-day activities to drive neuroplasticity. So we kind of get close to wrap this up. So if there's any questions, I'd be more than happy to answer them. Dietary lifestyle modification. Diet's important. We work hand in hand with a neuronutritionist that helps to kind of create a pretty good plan of action for mostly eating habits. Okay, and then maybe some little supplements here or there, but really mostly eating habits, focusing on getting the brain in the healthiest environment it can be in, right? So that when we give the brain these therapies, it can really take them, utilize them, and create some of that neuroplasticity. So Some basic things to understand: anti-inflammatory diet. Of course, we want to do things that's going to reduce inflammation in the brain. The act of these neurons kind of degenerating and losing the ability to produce dopamine is an inflammatory event. These things, the brain gets hot in some areas, so we don't want to give it more heat. We want to do things to reduce inflammation. Okay, so staying away from heavy red meats, heavy oils, bad oils, like the canola oils. You want to use things like coconut oil, grapeseed oil, avocado oil, olive oil. Those are the better oils to use. You want to eat more chicken and fish. You want to eat more nuts like almonds and walnuts and those types of things. Fruits, you want to stay away from heavy sugars with certain things, right? So you want to be more on the low glycemic end of things. So, for example, if you're going to have a fruit, I prefer to prescribe my patients blueberries or apples or pears or plums or peaches instead of watermelon, pineapple, things that have more sugar, which also can produce inflammation. You want to hydrate. Your brain is mostly fat and water, so you need to drink. Okay. If you can get in 5 or 6 8-ounce glasses a day, that would be great for your brain. You want to keep the brain fluid. Some supplements are good. There's not a ton of data that we can say, hey, these supplements work specifically for Parkinson's, but these are generalized good brain-based supplements like CoQ10, alpha lipoic acid, acetyl L-carnitine, which metabolizes fat, reduced glutathione, a really great antioxidant, essential fatty acids, that's always a player, and then B complex. So just some little food for thought things, no pun intended, to really gather some good information there regarding nutrition. Lastly, here are some generalized practical strategies. Some simple things you can do to spark general neuroplasticity. We talked about things being new, novel, engaging, that already stimulates the brain. But you can do simple things like using your non-dominant hand, your left hand. You do lefty Tuesdays, or maybe you say, hey, for the next 2 weeks, I'm going to just use my left hand. Maybe you do that every couple of months. Okay. Take new routes. If you're going to work or if you're going to do a walk in the neighborhood or going to the grocery store, take a new route. Travel is very good for your brain. You don't have to go to Europe. You can go to North Florida, South Florida, another neighborhood. Just travel, do something like that. A new grocery store, learning a new language, painting, playing a musical instrument. All these things create generalized neuroplasticity, some things to try to adhere to. So keep an eye on doing some of that as well. Okay, I left about 10 minutes here, but I have a QR code here, and that QR code, what we do with that is we have an email, monthly email that I put together with data, new things that are out, new research, new therapies, even medication. We didn't even talk about medications that much, but medication definitely, of course, has its role in this whole thing, and so we stay abreast of all new things. So if you're interested in that, or even if you want to come down and visit me in Delray Beach, Florida, which is just a couple hours away. We see patients from across the state, across the country. They'll come in and they'll work with us and do therapies. They may stay in town with us for a week or two and devote what we call an intensive therapeutic program, where they're seeing us a couple times a day for treatment. We really get great results doing these types of intensives. But if you scan the QR code, we'll put you on our list, on our email list, and you gather all of our data and that type of thing. So thank you so much.
Right. Well, thank you, Dr. Conde. That was a very enlightening presentation. I don't know about you all out there. I kind of feel like I just strengthened some synapses just listening to this information. Because seriously, when
There's a
you
lot.
learn new things, right?
Yep, that's it. That's part of it. That's right. That's part of it.
Yeah.
So
Yeah. So I do have a lot of questions, and I'm sure people out there do too. So what I want to, before I start talking about my takeaways, I would like for those of you out there in the audience who are still listening to go ahead and type your questions into the Q&A bubble at the bottom of the Zoom screen. That will give us a chance to answer them one by one. And for those of you who don't know who Neuro Challenge is, if you're new to us, we are an organization that serves the Southwest region of Florida. But since the pandemic, we really did reach out to, the whole United States and other countries to provide programs that are educational, therapeutic, and support groups. We also offer something called care advising. And again, everything we do is 100% free to people with Parkinson's and their care partners. So reach out to us if you need anything. And let me go to my list while people are typing in their questions. First of all, the phenotypes that you talked about,
Yep.
like that was such a great breakdown for me. I don't know. I like understanding that there's really two
Two.
kinds of
Yep.
Parkinson's patients.
That's right.
We kind of all know this in the Parkinson's world, but that was a good breakdown. Thank you for that
Oh, you're
reminder.
welcome. Of course.
And I think a lot of people will look at each other in support groups, at least where we are, and they'll be like, well, I don't have any tremors. Like, do I even have Parkinson's? Like they
Yep. Yep.
they will sometimes question whether they have it because they don't look like their neighbor with Parkinson's. And
Right.
I'm always reminding people that, everybody is presenting differently. And you meet one person with Parkinson's, you've met that one person with Parkinson's. So thank you for breaking that down
Oh
for
gosh,
us.
of course.
Yeah. And let's see. I do have some other
You,
questions. Okay,
you know,
I'm
you
glad
know,
you. Yeah, go ahead.
what's interesting and what talk about, how everybody manifests differently, and I didn't touch on this, but people get like they get blown away that this disease process starts about 30 years before we actually see a symptom, right?
Yes,
So it's
yes,
happening, and if we're trying to find research and different ways of us to be able to identify markers earlier so we can jump
yes.
on top of things, right? But 30 years is that it's crazy, right? To
I
think that
know. And that's why Neuro Challenge goes out and does a lot of like awareness
love
presentations,
it.
just
Great.
bringing that to the general public, the audience is people who don't even have Parkinson's, because we
Yeah.
want to explain that, you could have symptoms right now
Yeah.
today that
Yeah.
you're ignoring, that you're brushing under the rug because you think it's no big deal. But meanwhile, these are the actual symptoms
Yeah.
of Parkinson's. So
Right.
yeah, we
Right.
do a lot of that. Okay, so you talked about, and I'm glad you brought up nutrition. It was one of my questions. I wanted to know if there was anything specific that people need to focus on for good brain health. I'm glad you covered all of those things.
Mhm.
I do have a question. Reduced glutathione. I don't know that term reduced. I only know
Yeah. So
glutathione.
regular glutathione has a bit more difficulty getting broken down in the stomach. Okay.
Okay.
So with all of those, I love IV therapy the best, to be honest, because it bypasses the breakdown of all of this, the stomach acids and things. But if you're going to do glutathione, we like to do reduce, which means that there's an ability for it to get broken down easier and more absorbed. That's it.
So is that the same as liposomal?
Yeah, yeah, same type
Basically.
of
Oh,
thing.
okay. The
Yeah,
word was throwing me off. I'm like, what the
yeah,
heck is reduced?
yeah,
Okay, thank
same
you.
kind of thing. Hmm.
Okay, great. Another question. Your vagus nerve stimulation, you talked a little bit about
Yep,
that. So I love this concept. I know I've heard a lot of people kind of dabbling in whatever you're doing in the therapy in the clinic with this.
yep.
But how does that relate to the parasympathetic, sympathetic
Oh,
nervous system?
great,
Like,
great question. Yep.
are you trying to
Yeah.
impress upon that? Help me
Yes,
understand that.
for sure. So unfortunately, people are because it's such a fad right now, they're just using vagus nerve stimulation because they say, hey, it helps everything. You got to be careful because vagus nerve stimulation is a parasympathetic driver, right? And so if you are parasympathetically dominant and driven, and you give yourself a greater parasympathetic drive, you're really just making the system worse. And so
Okay.
we all think that everybody in society is just going is going crazy all the time. Everybody's exhausted. They're sympathetically driven. But you really have to test it. So we test it in the clinic. We do autonomic testing to see what's happening, right? To see if is there a dysautonomia, which is a kind of an aberrancy, and then what system is not working so well. And you'll be surprised how most of the time it's a sympathetic system that's not working very well. So that's when we'll use the other ones, the other nerve stimulators, what we call the trigeminal nerve. They're a little bit less of the parasympathetic, more of a sympathetic driver, or we may do things to stimulate the sympathetic more so than the parasympathetic. So really,
Right.
really a neat something important to know and to be careful for your audience here, not to just jump into to to doing vagus nerve stimulation if you don't really know what's going on.
That's great. That's a great point. Thank you. Um, Something that you were talking about, or I don't know if you touched on this, but it was coming to my mind. Um, so when we sleep,
Mhm.
it's right, like this is that, I forgot what it's
You-
called. What system is it in the brain? The glymph
Oh,
system?
glymphatics. We didn't
Oh,
even get
thank
into
you.
glymphatics.
Glymphatic. That's
Yeah,
it. So
glymphatics is
like,
fantastic. Glymphatics.
isn't this very important for people? I mean, it's important for everybody, but for people with Parkinson's to get adequate sleep so that happens. And what is
It
that
is
that's
so
happening?
important. So the glymphatic system, so at night, we've now in the last like 5 years, we know that we start to get rid of all of our debris, all nerve debris, things that are slowing us down, things that that are toxic or. So there are systems that drain, just like the lymphatics, they drain out of our brain, right? That's called the glymphatics. And so at night when we're sleeping, that's when we have the greatest amount of lymphatic activity going on. Now, so you've heard data on sleep that 6 to 8 hours. I really would tell you 7 to 8 is really better and really the best. Um, in fact, they did a longevity study, and one of the markers for people that lived the longest were they were sleeping in 7 or 8 hours a night. Okay, so that's important.
Right.
Now, one more thing with the glymphatics, if your audience knows what a cat camel is, like a yoga pose type of thing,
Oh yeah. Hmm.
a cat camel is a great way to also get some glymphatics moving in the body and kind of getting it. Yep, that's something that's been
That's
out there
excellent
now.
to know.
Yeah, yep. So
Oh.
so the cat camel, that yoga pose or
Mhm.
posture where you go up. Yep, that's it, and we'll use it here, and of course other things with that. But that's an easy one to do.
Okay, great, great. And of course, getting good sleep. Yes.
Yeah. Oh gosh.
Okay, and then I'm going to jump over here because I see now people have put some questions. We got about 8 of them there. Okay, let's go real quick to memory because I wrote this down. Let's say I wanted to activate certain, I don't know, memory neurons to be working better, right? This is a
Yep.
big problem with Parkinson's. We're having cognitive decline, and maybe it's not dementia, but it's just some memory, little bit of decline in the memory, right?
Uh-huh.
So, like, is that what you do at your clinic too? Is like also to
Oh, for
help to
sure.
improve the memory, the
Cognitive
basic?
activities. Yeah,
Okay.
so we use some pretty advanced medical software that once we ascertain like what domains of the cognitive system the patient may be struggling in, because it's not just short-term memory. There's processing,
Yeah.
there's sequencing, there's reaction time,
Mhm.
there's all kinds of things. So once we can look at, then we can use the software and say, hey, we're going to hit these areas with these specific X games or therapies that are going to really, they're validated, evidence-based, that are going to trigger these domains to get stronger.
Yeah.
So yes, absolutely, we do a
Okay.
lot of neurocognitive therapy.
Oh, good, good. Okay, because I was writing that down as I was thinking.
Yeah, for
Oh, and the
sure.
mirror therapy, fascinating,
Yeah,
absolutely
really cool,
incredible
very
stuff.
cool.
That's great. So
Yeah,
let's
it's
jump
really
over to
neat.
the questions. I'm going to read them out loud to you,
Of course,
and then you can answer. Okay.
no
This
problem.
person lives in Arizona, and they're wondering if you know of any locations that you can refer people to. I'm sure you guys have a network, right? Functional
Oh, for
neurology.
sure. Yes, yeah. If they're in Arizona, that is pretty far. I do have somebody there that I would recommend.
Okay.
Um, maybe
You
they
can
can.
email it to me, and
Yes,
I can get it
that'd
to
be
this
great.
person.
That'd be great.
Okay.
Or if they do my little QR code thing
Yeah.
and put on there why they're contacting me, that way I remember. We'll send
Okay.
them that practice. Yeah, they're
So
they're 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 great.
that's a great idea. Okay, so to the person who asked that question, if you could go to his QR code, and then just put a question in there about your
Yep,
Arizona contact, that would be great.
that's no
And
problem at
another
all.
person says, for the young onset Parkinson's population, do you suggest starting this type of therapy and training?
Oh gosh, right away, right away. I mean,
Mhm.
the faster the better with this, and it just the faster we can get in there and start changing some of the networks, the more they respond, the
Mhm.
easier they respond. It's like anything else. If you leave it kind of, entrenched for a long period of time, it's hard to take all the layers off as we
Yeah.
go, right? So, I mean, we do it, but it's if we have the ability to do it early on, it's always better.
Yeah, absolutely. And somebody's wanting locations near Manatee County. Again, you can go to his QR code. And if
Yeah.
also Neuro Challenge may have some contacts for functional neurology in Manatee County. So certainly reach out to Neuro Challenge as well,
Hmm.
and ask for Diane, and she can give you those resources. Let's see. How does one get into an intensive treatment program? I might actually be able to get to Delray.
So real easy. You can on the same QR code, you can put that you would like to schedule an appointment, and then our care specialist will reach out to you and kind of interview you a little bit, talk almost like a consultation. She's an extension of me. She basically should be a doctor. I mean, she's great. She'll just kind of do a little consultation, see if you're a good candidate for what we do, and then just get some basic information and then schedule you, and that's it. And then you come in. Our testing is typically done through either one long appointment or two appointments because we like to get a lot of biometrics so that as we're kind of doing our rehab, we want to. I not only do I want to hear that, hey doc, I'm feeling better, but I also want to say, okay, great, you're functioning better. I see these numbers are better, they're improving, and that type of thing. So, but yeah,
Right.
super easy. QR code, put in that you want an appointment, we'll reach out, and easy.
Great. And if you happen to go over to Delray Beach, I don't go over there very often, but there's a beautiful Japanese garden, right? Isn't
Oh,
there?
well, yeah,
There you go.
Murakami
Yeah.
Gardens.
Oh,
Yeah,
I've
it's a
been
great,
there. Yeah, if you
it's
happen to go
super
over there,
neat.
make a stop over there.
Yeah.
Okay.
And one
Somebody,
more thing with that, I'm sorry, one more thing with
yeah,
that. If you're coming out of town, she also is like does all the concierge stuff. She'll get a hotel for you or VRBO, whatever budget you
nice.
have for that. She'll do it all. So she's great. Mhm.
Excellent.
Sorry, thanks.
All right. This question, has this been crossed with acupuncture? They seem related.
So I don't know a whole lot about acupuncture. I know that it works for many things. One of my doctors does some level of dry needle as well. So yeah, there is some cross for sure. I don't know enough of how they cross or what they do, but I do know that when I do talk to one of my docs in the office about trying to do something using that, we're gonna use the needles in a certain way that may activate brain, kind of in the same way as a sensory therapy would. Okay,
Yeah,
but it does. I mean, there's definite good effects from it for sure.
sure. Okay, here's a question. I've heard that bilateral movements that cross the midline are good for people with Parkinson's. Boxing is an example. Is this true? And is this related to neuroplasticity?
Yes, bilateral cross movements are very good. Yep, boxing is great. You don't need a punching bag. You can just air box.
Mhm.
There's actually a ballet classes or dance classes that are Parkinson specific right by me in the area, which I
Yeah,
love too.
we have those too.
Oh,
Yeah.
good.
Yeah, over
Great. I
here, but
love them.
that's great. Yeah, we
Perfect.
have
Aren't they great?
the
They're awesome.
evidence-based ones.
Yeah,
Yes,
the evidence-based ones. Yeah,
hmm hmm
in fact, I went and attended one just because I wanted to see what is all. It's fantastic. They do a great job, and they do
yeah.
incorporate cross movements and that type of
Yes. Yeah, they're
thing.
amazing.
Yeah,
Yeah.
they're great. And but even things like pickleball is
Yeah.
great.
Yeah.
If you can get out and move a little bit, it has a great level of cognitive requirement as well as having to sometimes have to cross body a little bit. So
Yeah. And
those
Tai
types of things are
Chi
great.
and
Tai Chi
yeah, yeah.
is fantastic. Tai Chi's
Yeah.
been around forever
Yep.
as a tried and true Parkinson's type of exercise.
Exactly. Another comment is my physical therapist had me walking backwards yesterday. Is this an example of plasticity?
So backwards walking, that's I love backwards walking. In fact, we measure backwards walking. There's certain specific measurables that we use, and we know what norms should be. So we'll measure. It's called the 3 meter backward walk test. There's a lot of data now on backwards walking. So the answer is yes. Um, and it helps to use more of the cognitive centers of your brain, which helps the overall gait. So the answer is yes. I like it.
Very good. I've been told that my vagus nerve uh, might be responsible for some of my syncope episodes. Is a nerve stimulator something I should look at?
Yes, it is, but it depends on what is causing your syncope because there are many different reasons, right? You can have a vagal episode that's because of an issue that's creating reduced heart rate, those types of things. But you can also have different reasons that you have a syncopal episode. So before you get a vagus nerve stimulator, especially if you're having syncope, I'd probably see a practitioner first, somebody that can kind of give you an idea or have a look or something that can kind of steer you in the right direction with that. I'd hate for you to
Mhm.
have vagal episodes and then go and stimulate and it's too much or too little and then it can
Mm.
produce another episode.
Yeah. Yeah, definitely get somebody trained in that area. Okay, another question. I accessed the QR code and entered my information, but it didn't indicate that I was in Arizona. Should I fill out the form again? Hmm.
Um, if can that person give me the name and I can write it down right now, that would be easy if that's
Yeah.
possible.
Yes, this person's name is Jennifer.
Jennifer.
Last name starts with a Z.
Z as in zebra.
Please don't, I'm not going to say it on this
No, no, it's
webinar because it's
okay.
being
Z
recorded,
as in
but last
zebra.
name starts with a Z.
Perfect. I'll look out
Okay,
for that. Yep,
thank
no
you.
problem at all. And one more thing about the autonomic system, we didn't even get into this, but with Parkinson's, quite often we have dysautonomia. So the
Yes,
autonomics aren't working well. You know, there'll be dizziness, lightheadedness, get up too quickly, fatigue, faint, those types of things. So
difficult regulating temperature, right? That's all
all
part
of
of that
that,
system.
regulating
Hmm.
temperature, all of that. So we have to measure the autonomics because we don't really know if it's occurring because the sympathetics are working too low or the
Yeah,
parasympathetics are too high.
yeah,
So I'd be very careful to just throw a nerve stimulator on you,
yeah.
before measuring it properly.
Very good. Another question, tips on dealing with rigidity in the head and neck.
So I like something called head-eye following exercises, and basically what this would be the easiest way to put it. You can sit in a chair and you can do a progression. The first thing you can do is sit keeping your eyes on a target, and then you need a rolly chair, one that can move and rotate. Keep your eyes on the target and just rotate your trunk minimally one side, the other side, while you're keeping your head and your eyes on a target. Does that make any sense? So my head's not moving, but I'm moving my trunk, okay, on my rolly chair, and I'm keeping my eyes on a target. Okay, that disassociates the head and the neck, and it creates some simplicity there with that motion. Of course, in our office we put a laser on your head, and we're doing all kinds of other crazy things. But generally speaking, if you're looking at a light or a target, and you're able to keep your head straight and move the body, it's a great activity.
Very interesting.
Yep.
Somebody else commented that indoor rock climbing. I'm assuming you meant that it's this person maybe that's also bilateral, so that's a good
Yeah, that's a
exercise.
good thing. That's a good thing.
Okay.
Yeah. Just be careful.
Exactly. And
Yes.
then the final question we have in here is NOH part of Parkinson's? I'm not sure what they're referencing.
NOH. Maybe
Can you tell us more about what that means, NOH?
nitric
We're
oxide or
oh maybe oh I'm sorry, maybe they're talking about chemicals. Okay, I don't know.
certain
Let's
chemicals.
if
Okay.
they come back and answer
Yeah, for
to the
sure. No
person who
problem.
wrote that, if you could answer again, we or ask the question in a different way. We're not sure what you mean by NOH.
Hmm.
Okay, let us know. All
Yeah.
right.
Yeah,
Maybe if
for
they put
sure.
that question that back in there, we'll have time to answer. But
Yeah.
otherwise, this has been just a wonderful
No,
presentation.
great.
Thank you
I love
so
doing this.
much.
Thank you so much. I mean, and there's so much more we could have talked about. I know I talked
I
like crazy, but
I know I'm so excited to talk to you about all these things, but I think we could do another one some other day. Give
yes,
us
I
another
love it
topic
and bring
idea.
different
Yeah.
things and it'd
Yeah.
be great. It'd be great. I love doing this. Thank you for the opportunity. I really
Yeah.
appreciate it. So,
Thank you very much. And you all have a great day out there. And
all
this will
right.
be on our YouTube channel in a few days. Thanks again.
Fantastic. Thanks so much. Take
Bye-bye.
care. Bye bye.